Thank you all for being here. Welcome to, I don't even know how many meetings we have. This is the 5th meeting of the Medical Marijuana Working Group. By now, everyone knows I'm Senator Greg McCourtney. This is my co-chair, John Eccles. I will be running today's meeting. So we have today 2 doctors to start off the meeting, and then after that we are going to stop the flow of invited guests, and we have just invited people to come and sign up, people from the general public, to give their thoughts to us. And so we'll go into more detail of exactly how that is going to work as we move forward. If you would like to speak in that general public portion of the meeting, there's a sign-up sheet back here. Caden is holding it up in the air. In all honesty, I think there are already enough people signed up that if you sign up now, we probably will not get to you. But just in case everything moves faster than we think, if you would like to sign up, we will have a break in just a little bit after the doctors go, and you'll have the opportunity to add your name to the list at that point. So with that, Co-Chair, do you have any opening remarks before we get into the meat of this meeting?
No, I'm really looking forward to today's meeting, and I'm excited so many people showed up, and I know it's intimidating to talk in front of a large crowd. If you're disabled, we're going to bring a chair up here. I've had at least one person who's disabled who's said they need to sit down, so I want them to know if they, just because they don't see it doesn't mean I didn't think about it, and we appreciate you coming.
All right, with that, I would like to add one change to the agenda that was published. Dr. Stephen Wilson is not going to be speaking to this committee, but we have asked Dr. Doug Cox, who many of you, if you've been around the Capitol, know Dr. Cox. He was a member of the House of Representatives for many years, and so he is going to be filling that spot. But we would like to start today with Dr. Mike Mullins, and so Dr. Mullins, if you would take the podium, introduce yourself, and the floor is yours. Thank you very much for being here.
Thank you. You'll have to forgive me. I don't normally speak in front of an audience anywhere near this size. In fact, if it's more than a couple of grandkids and a dog or two, it's amazing for me. But thank you, Senator McCourtney, Representative Eccles, members of the 788 work group. I appreciate the opportunity to appear. My name is Michael Mullins. I'm an anesthesiologist from Norman, Oklahoma. I practice in a small group there. I'm a graduate of the University of Oklahoma College of Pharmacy, as well as the College of Medicine. I've been in practice for about 30 years. I am here representing no one but myself. I have any association with anyone in a medical association that I'm representing today or any other groups. And the focus of my presentation is very narrow this morning, and I hopefully will be very short. And it is concerning my perceived role of the physician in the working of the medical marijuana program. From the outward appearances of the regulations that I've seen thus far, we have a very limited role. It's a role that is very short. It's not anything that we have experienced before as physicians with our patients. In fact, a great number of the people that we will see, except for possibly patients that we have that are already established in our practice, we may never ever see again. This is more along the lines of less of a patient-physician experience as so much as it probably is more along the lines of a consumer-physician relationship. And the reason I'm saying that is because of the way that the regulations that I've read have been presented to us. In fact, it seems that the doctor in this relationship is being reduced to that of a straw man to lend some degree of legitimacy to recreational marijuana. Now, let me stop at this point and tell you, I have no opinions about plus or minus about recreational marijuana. If the citizens of the state of Oklahoma would like to have recreational marijuana, let's put it on the ballot and let's vote it and see where it goes, because honestly, it's something that's probably overdue to be addressed in this state. But the role of the physician in the medical marijuana program as it's currently designed is very minimal. There is not set up any, in this current program, any way for a discourse to be allowed between the patient and physician. And that's something that happens in every therapeutic process with a physician and a patient. We don't just simply see the patient, make a diagnosis, treat them blindly, and never see them again. The physician and the patient have a relationship that is brought about through discourse. We do have the ability to talk with the patient, discuss therapeutic options with the patient, hopefully discuss risk versus benefits of the therapeutic options, and then continue with follow-up with the patient following the institution of the therapy. I know that with my physician and I, we have a very, very robust discussion about things. And it's something that I hope every patient has the ability to do with their physician. But the way this is set up, the personal relationship with the physician is probably not going to be there. And it's probably going to be more along the lines of us brokering licenses to consumers. The patient comes to us, they present us with their desires for obtaining a license and through the State Health Department's medical marijuana program. We sign that application, it's taken to the State Health Department, the State Health Department issues the license, and then the person goes to a dispensary and they obtain whatever product that is deemed beneficial to them at the dispensary. We have no idea what they're obtaining. They honestly probably don't have any idea what they're obtaining either, and that's what's concerning to us. Our role is very small. It is not the traditional physician-patient relationship. It has no ability for us to discuss risk versus benefits or even whether or not there's any benefits to be had. This is concerning to us. We don't feel like this is an appropriate, and in fact, I say we, I'm talking about me and the mouse in my pocket apparently, but I don't feel like this is an appropriate role for the physician. We don't have that ability to discuss that. And some of it is because of the federal regulations that are placed upon us because of the classification of marijuana being in the Schedule I section of the medicinals. The federal government doesn't consider this to be a medicinal product that has any benefit to the patient. Therefore, we cannot discuss anything to do with therapies with patients or risk versus benefits with patients at all. Our role is, yes, you would like a medical marijuana license? Well, I hope it benefits you. And we sign the application and away you go. Some patients are going to come back to us and they're going to be our patients. A lot of people are not going to be. And the program is not clearly defining what the structure of the physician is in this process, other than we're brokering licenses. And that's not the purpose of a physician in a therapeutic sequence with a patient. I think that's basically all I had to say. This is a very, very troubling time. You know, and if you want a medical marijuana program, let's put one down. Let's let the legislature work with the legislature. Let's work with the legislature. Let's try and design something that puts the patient in the best possible position that they can be in. And that is under the guidance of a physician. But until things change at the federal level, some of that's not going to be possible. But let's separate the idea that we are a valued participant in the program the way it's designed, because we're not. Other than we are going to be signing a license application that the patient has requested, and that hopefully will benefit them in the long run. I deal with brain chemistry every day. This is something that I see. This is my practice. I understand things. I understand the way that this is a chemical that is going to affect the brains of people. It is not a benign process. It's not a benign chemical. Just because it's being dealt with as a nutraceutical doesn't mean it's benign. It's not as bad as some people want you to think it is either. It all falls in the middle. Properly taken care of by the patient, properly taken care of, the patient being properly taken care of by a physician, is an appropriate manner to handle a medical marijuana program. The way this program is designed is the physician is not operating in the system as a physician. That's all I wanted to say today. Thank you very much. This is the views of one private physician. I think my medical association is going to come speak next week. You'll probably hear some different views after that. But thank you very much. I appreciate your time.
Thank you, Dr. Mullins. And Dr. Mullins, I forgot to say earlier, Dr. Cox is going to present, and then we will have time for the members of the committee to ask both of them questions at the same time. So with that, we'll call Dr. Cox to the podium and hear his portion of testimony.
Thank you, Mr. Chairman, members. It's great to be back at the Capitol. It's just my second time back since I finished my term limits last go-round. By way of background, for those of you who don't know me, I am a retired emergency room physician after 18 years with Integris. Prior to that, I practiced family medicine for 18 years, delivered about 413 babies. Presently, I work part-time as co-medical director of the Wyandotte Tribal Nation, and my views here today are in no way the views of the Wyandotte Tribal Nation, may or may not be. During my time, my 12 years in the legislature, I spent 4 years as chairman of the Public Health Policy Committee in the House of Representatives, and 6 years as chairman of the subcommittee on health care appropriations. Lo and behold, most people don't know that I authored and passed Oklahoma's first medical marijuana legislation. We've had medical marijuana in Oklahoma since I believe it was the year 2006, when I authored and passed very quietly, my how times have changed, the bill to authorize the use of Marinol. Marinol is a non-mood-altering extract of marijuana. I authorized in that legislation access to that drug by 2 cancer patients who were receiving chemotherapy as a way to combat chemotherapy-induced nausea. It was also approved for use by cancer patients to combat their loss of appetite. Now that legislation, as I think legislation should be, was based on science. To me, this is true medical marijuana. This drug was studied and approved by the Food and Drug Administration. We knew what dose was appropriate, we knew what dose was too much, we knew what side effects to expect. That's true science, and to me, that is what medical marijuana should be. Now, I will be the first to admit and tell you that I'm the first one to enjoy that indeed medicine is not all science. There is an art to practicing medicine. But legislation should be passed based on facts and science. There were a lot of anecdotal stories today and in the past. Well, even when I did the medical marijuana bill, there were anecdotal stories about how spraying WD-40 on your knee can help your joint pain. Turns out it wasn't true. I didn't pass legislation dealing with WD-40. There was anecdotal stories about how you could eat 6 gin-soaked raisins a day to help your arthritis. Some of your grandparents may have tried that. I think my mom tried it. She loved the gin, didn't care for the raisins. I could have passed legislation based on anecdotal stories about gin and raisins for arthritis. but I chose to stick with the science. There was a lot of anecdotal stories about Laetrile. Laetrile was an extract of apricot seeds, and everyone thought it would cure cancer. Well, our Food and Drug Administration tested it. They said it doesn't cure cancer, so people were going to Mexico by the thousands to get cancer treatment with Laetrile. A lot of them would die down there. It's not easy to get a body back from Mexico if someone dies in Mexico, I'm telling you. I didn't do legislation regarding Laetrile. That was anecdotal stories. I chose to do my medical marijuana legislation based on science, and I think that's the way it should be. And if you want to get some good science, and I think all you members have probably seen Commissioner White from the Department of Mental Health and Substance Abuse Services, her presentation. If you haven't, you need to, about how marijuana and illegal street drugs affect the actual chemistry of the brain that my predecessor mentioned, and how the younger you are and the more you use mind-altering drugs, including marijuana, how there are more changes in the brain and the more long-lasting those changes are. That's the type of science I hope that you become familiar with when you consider legislation. You know, I realize that the federal government treats marijuana as a Class 1 substance. And I found out as a legislator why. And I think you all probably have already done this. If not, you need to. You need to tour our state prisons. I toured the medium security prison at McLeod. You need to tour our state-operated drug rehab centers. And as the chairman of Appropriations for Health Care, which oversaw the budget for the Department of Mental Health and Substance Abuse Services, I had the opportunity to tour many, many state-operated drug rehab centers as well as many private drug rehab centers. Now, it's easy on these tours to walk around and listen and say, oh, this is a great facility, their outcomes are this, their outcomes are that. But when you tour those facilities, take the time to talk to the people that are there, to talk to the people that are in drug rehab. I ask every single person in drug rehab that was there for rehab of illegal street drug, I ask every one of them I met, hundreds, if not thousands, what was your entry-level drug? 99.9% said it was smoking pot. There was one woman who said her entry-level drug was diet pills that she started on after seeing a great show on Oprah Winfrey about super soccer moms that were on diet pills. But everyone else, without exception, on illegal street drugs, I'm not talking about opiates, that's a whole different story, but on illegal street drugs, every single one was smoking marijuana. So I encourage you to tour those facilities, ask the hard questions, get the answers before you finalize any legislation. We talked about Commissioner White's presentation for the Department of Mental Health. Again, you need to see that. One of the things that we know, and she points out, and I hate to admit this in front of all these ladies in the room, but we know that the male brain really doesn't mature until about age 23 and 25. There's scientific proof and facts, guys, that the girl's brain matures a little sooner. That's probably why males are more susceptible to addiction and actually some of the changes in the brain at an early age. We know that the earlier a male starts using marijuana, the mind-altering form of marijuana, what we call the psychotropic form, the more likely they are to develop what is known in medicine as the amotivational syndrome. Chronic pot users tend to develop a lack of motivation. It affects the part of the brain that encourages you to get up, get out of bed, go to work, and have a productive life. I mean, we all know, for lack of a better term, I don't want to offend anybody, potheads that lay around and smoke marijuana all the time, and that's their main goal in life, is to decide where they're going to get their next hit. And that's not everybody, but we all know some of those people. Now, don't get me wrong. I've already said I passed the first medical marijuana bill. I support 100% the 9 psychotropic, non-mood-altering extracts of marijuana, such as CBD oil. There will be more and more of these extracts come out that go through appropriate testing through the Food and Drug Administration and get approval for use. The problem is the psychotropic, mood-altering forms of marijuana, particularly pot smoking, that tends to be the entry gateway into addiction. Now, let me say that people tend to badmouth the Food and Drug Administration, but I think you should put some credence into what they say. Remember, if it wasn't for them, we'd probably still be having thalidomide on the market and babies being born without arms and legs. That's how the Food and Drug Administration came into being, to combat and regulate drugs that had harmful side effects. I'll close with 6 things I hope you remember as you consider legislation. There's a lot of talk about, hey, this is going to be a great savior to the state budget. We're going to take in a lot of tax money from this. And indeed we may. I will predict, we'll see if it's true, may not be, but I want you to mark this day and mark this comment. I'll probably be dead and gone, I hope not, but I would be willing to say, how many freshman legislators are there here today? There's a few. Now you guys, I hope you all get to serve your 12 years. But I am here to say that I would bet, dollar to a dime, that after 10 years, give it 10 years, that you will be spending more state tax dollars addressing the problems associated with any legal form of mood-altering marijuana than you will be taking in on tax dollars from that same substance. I would also like to remind you that the cigarette manufacturers said, oh, don't worry, these things aren't harmful, even after they knew they were. Now then, cigarette smoking is the #1 cause of preventable illness and preventable premature death in the United States. I would remind you that the opioid manufacturers said, oh, don't worry, this new form, these oxycodones, these hydrocodones, they're not as addictive. They're not that harmful. And now then, the United States has more citizens dying from opioid addiction problems than they do car wrecks. I'm also fearful of the folks that say smoking marijuana is not that bad. You know the old saying, fool me once, shame on you. Fool me twice, shame on me. I don't know what we say after the 3rd time. Maybe we're not too smart. We'll see. I'm also concerned that according to the press, the draft language that you've seen for this bill comes from people who stand to make a profit from this bill. Now, I don't know about you guys, but when I was in the legislature, I always looked at stuff like that with a jaded eye, rather skeptical, and I would encourage you to do the same. You've heard, well, it may be illegal now, but don't worry, we're going to put doctors in charge of it. Now, I hate to admit this as a doctor, but that's not a prevention. That's not a cure. We tried that with opioids. How did that work? I also authored the bill that requires physicians to have to check by law the prescription monitoring program before prescribing opioids to a new patient every 6 months. I'm in a lot of opposition from some of my colleagues, but I'm proud of that legislation, and I think it's making a difference. So don't be fooled that just because someone has to go visit a doctor, that's going to prevent abuse and prevent some of the problems that I've talked about. It hasn't. It won't. I like to think that the people of this great state voted for medical marijuana. I think the initiative petition folks that designed that, they were very smart by putting the term medical marijuana on there. Even though when I read the bill, I thought, this is kind of legalizing recreational use. But so many of my previous constituents said, well, I want to help people get out of pain. I'm kind, I'm compassionate, as am I as a physician. But I think that the term medical marijuana got a lot of votes. But when you read the legislation, it's not strictly about medical marijuana. I think the health department, with their initial regulations, tried to make it medical marijuana. I was very proud of the health department board. I was disappointed when they backed down and changed it. And I was disappointed when the governor, who was such a great ally of mine addressing opioid addiction, signed off on their second set of rules after signing off on the first set. But that's neither here or there. That's water under the bridge. But people voted for medical marijuana, not recreational marijuana. So again, I urge you to stick to the facts, the statistics, and the science. And lastly, reminder again that marijuana is a Class 1 federal drug. There's a reason for that. Do your research and find out why. Thank you.
Thank you very much. We will open it up to questions. I will turn to my co-chair and allow him to start with questions, and then we'll move on down to the rest of the members of the committee.
I've just got a couple. Thank you for that. Dr. Mullins, it appeared to me one of your arguments is there was going to be no discourse between patients and physicians. I don't understand that. Right now, a patient goes into a physician and gets a prescription. It's that patient's decision whether or not they come back to that physician later on. Under the language of 78.8 as passed by 57% of the voters, a patient would then go to a physician, get the card, and it's their decision whether or not they come back. How is that any different, in any nature at all?
First of all, it's large. The current issue is that the federal government considers marijuana to be a Schedule I compound. And that forbids us from having a discussion with the patient about anything concerning this. It's Schedule I chemicals or Schedule I substances are deemed to have no accepted medical use by the federal government. They're also on that schedule because the federal government considers them to have any lack of accepted safety under medical supervision. And the third thing that puts it in Schedule I, according to the federal government, is that it has a very high abuse potential. That they tell us at that point, you don't speak with the patient about anything concerning a Schedule I substance. We're locked up in that regard. This is not one of the situations where we can come in and have a detailed discussion about whether or not your Parkinson's or your rheumatoid arthritis or whatever concerns that you have, multiple sclerosis, has any potential benefit from the use of marijuana. We can't do it. It's not something that we can do. And secondly, this is not prescriptions that we're handing out. This is not something that we come in and the patient comes in, they present the problem to us, we do a thorough medical examination, we, if necessary, obtain some type of follow-up laboratory or appropriate radiographic studies or whatever other studies we need. If it's a seizure disorder, it would be some type of an electroencephalogram. The things of nature, the things that are routine for the diagnosis of that condition. That's not happening here. This is simply someone, the patient coming in and saying, I have this condition, I think it may be beneficial for me to try this, and we're not signing, we're not giving any type of therapy or prescription to the patient to go obtain from a pharmacy. We're simply signing a license for them to obtain their medical marijuana license.
For follow-up? So I understand what you're saying when you say that. The problem I have is in the state of Oklahoma, I actually have some pretty significant experience with this type of issue. Back in 2014, when we passed Katie and Cayman's law, it was actually still federally illegal for doctors to, it was on the same Schedule I till the Farm Act made it legal. And we had doctors that came to this committee, the last joint committee we had, like say Dr. Amy Stauffer, pediatric neurologist out of Tulsa. We had the head of pediatric neurology for Children's Fort Worth. And these were doctors that did talk about it with their patients, that had great detailed discussions. It was on the exact same ban list that you're talking about, identical. And in my office, because I still get calls 6 years later about that bill, I have a list of about 12, 13 doctors that are very knowledgeable on that topic. So I get calls from adults to children saying, hey, who do I go see? I live in Muskogee. And I can say, Dr. So-and-so, that they're doing it. So what I'm struggling with what you're saying, and I do mean I'm literally struggling, is those doctors were having an identical patient relationship. It was actually a much looser system. All that bill allowed, instead of requiring a license, was that they just be under the care of a physician. That was it. There was no license. There was no nothing. And those patients were able to find physicians that were detailed, that talked with them, that had that experience. and it was no different. They could follow up, or they could walk into a physician and get opioids, and they could not follow up. I understand what you're saying about the FDA, but help me with that past experience where it has worked in Oklahoma as far as the physician relationship with the FDA. Why would this be different?
Well, in that regard, this is a very narrow area as well, because you're dealing with primarily the folks that have children with the severe epileptic syndrome. And fortunately, the FDA in the past 90 days has released a compound that is a cannabinoid. It actually is the only cannabinoid that's available on the market currently. The others are not cannabinoids. But Epidiolex has been released for the treatment of Dravet syndrome and Gastelino, which they're probably the two syndromes that you were talking to the pediatric neurologist about. And it currently is a substance that it has been refined. It actually is a plant-based cannabinol that has been refined to the extent that they have removed some of the psychotropic effects from it, and it's very effective in the treatment of these two things. And I understand that was probably some areas where, because the focus was very narrow and the focus was honed down onto one specific area, that there was probably a little bit of leeway given to the physicians who were discussing this with their patients, because these patients had no other remedy that was actually providing them with any ability to recover. These two particular epileptics, very narrow areas of epilepsy, are very, very troubling. The first, Dravet, is a syndrome that occurs in very, very young children, and Gastelino is one that occurs in older children. You're still talking about kids that are well under the age of 5. They're both very disabling, and they're both left with children that have extreme neuropsychological developmental delays. And so I think with that regard, that's the reason why you saw a great deal of latitude being given the physicians that were taking care of these people, because they had no other way to go.
And final follow-up. And I have quite a bit of knowledge about Dravet. That's what Katie has, and respectfully, if she would have waited for Epilex, she'd be dead right now. Yeah. I mean, that's just
I understand
the reality.
And I think that's one of the reasons why they were given the latitude that they had, is because you're talking about a very debilitating disease that affects very few people, but at the same time, the ones that are affected are extremely debilitated. And your remarks, I understand completely. It is something that, but here again, it was a very narrow area of medicine that they were given the latitude to work within.
Perfect. And final follow-up, I just wanted to make sure you know it's not just children with seizures now. It's about 10 other disorders.
There are some others, but they're not as well defined. Yeah, I understand that, and the process has not been as well investigated as it has. And I understand, and in fact, this may wind up being a very fine form of therapy for a great deal of patients with epilepsy. However, because of the nature of the way that these compounds have been treated by the federal government, there's not been a great deal of clinical trials done. And that's what our problem is. We could go back and forth all day, because I disagree on the clinical trials too, but I want to talk to Dr. Cox on, Dr. Cox, you and I served together. I'm going to ask you a very pointed question, sure, and I'm going to take liberty with our friendship, that you know that it is set out of friendship, but you sat in my chair. You were a legislator. You know what we did, and you said something that worried me, and I just want you to respond to this concept. You were talking about essentially the legislature divining, for lack of a better word, the will of the voters.
I personally think that's dangerous. I think the will of the voters is in State Question 788, and that everything we do needs to go back to the language of State Question 788. I understand what you're saying, because you and I have been through a lot of elections, and you know, 1 million people cast a ballot, and I don't know what they all think. But as somebody who has sat in my chair, to me, that's dangerous. And I promise you I will not have a follow-up. I will just listen to your answer. But try to convince me that I should divine the will of the voters and not follow the language of 788.
I think the language of 788 is so broad that it's up to the legislature to fill in the blanks. I would remind you and compliment you on your great work on Katie's Law, but I would also remind you that what made that easier to pass is that the treatments that you were addressing were treatments that involved non-mood altering extracts for seizure treatments. And I support that. And I hope that the legislature will fill the gaps in 788 and narrow it down to the non-mood altering forms. As you have heard, once we write that card for someone, we have no control over how much someone is going to use, what types they're going to use. I hope that the legislature fills in the gaps. I don't think that the petition addresses this. What happens to someone who takes that card, goes and gets marijuana, and then turns around and gives it to someone else that doesn't have a card? Will that be addressed just like someone who's exchanging their opioids? I think it should be. So I don't want to go against the will of the people, but I think that the way the bill was written, unless the legislature steps up and fills in the gaps, that it's going to be willy-nilly with very little guidance or rules. And I think in the interest of doing the legislature's job, which is to serve the public and protect the public, that it's your duty to step up and fill in the gaps.
Representative Fatgetter.
Thank you, Mr. Chairman. Thank you, gentlemen, for your presentations today. I understand your concerns. With that being said, I've been somebody who in the past has been very against the use of marijuana, because I have seen some of the, you know, the negative effects to habitual users. With that being said, I had to put my personal feelings aside whenever I got involved in this process and look at it from a different angle. So, Dr. Mullins, you talked extensively about this changing the relationship with the doctor and the patient. And I've never felt like, as a legislator, it was my role to tell you how to do your job. So if it's going to change that relationship, I think that's up to you whether it changes the relationship. How often you will reschedule follow-up appointments and those types of things. Tell me if I'm wrong, and tell me how that relationship is being changed and what you would like to see differently from us.
Actually, the relationship that a physician has with the patient is a two-way street. It's one of those where you either return to us because you're satisfied with what you're receiving from us, you're satisfied with your care, or we never see you again. And a lot of physicians are going to have established patients that do come to them and are seeking their medical marijuana license, and they will probably have a much more robust discussion with the patient about, and then have follow-up with the patient. There are going to be some patients that, regardless of whether or not we ask them to return to us, we're ever going to see again, and we're not going to have the ability to have that discussion with them about whether or not they're receiving any benefit. This is not a situation where we are, like I said, that we're prescribing anything. We're simply seeing someone, we're signing an application for a license to obtain a substance and they're submitting their application to a state agency who may or may not give them that license, but if they obtain the license, they're under no obligation to ever see us again, except probably the next time that they're in the 2-year, when the 2 years is over, for them to receive another license. There's not really any, with the exception of the ones of us that have established patients that we're probably, that may opt to go off onto this program, there's not really any requirement that we can have of the patient to come back to see us for continuing therapy, because they have a 2-year window there to obtain their product. You know, the other end of it, we have no idea, neither do they, of what they're going to obtain at the time that they go to the dispensary. There's myriads of ways that you can use the compound, the marijuana. I mean, there's edibles, there's smokables, there's, I'm sure, other types of products that I'm not even familiar with that they can, and there certainly is currently the cannabinoids that are not going to be regulated that are available that have no psychotropic effect at all and may have some benefits. The fact that we are signing an application for someone is not really constitute a therapeutic relationship with the patient. There are some patients that are going to come back and see us. Thankfully, that will be something that we can have a discussion with these patients concerning their care, whether or not they are receiving benefits from us. It will probably teach us a lot about an area that we've never experienced before, and I hope that's the case. But the way that the system is, the way that the regulations are designed right now, you know, the path of least resistance is where I see this going.
Yes, he wanted to follow up.
I just real quickly, maybe it's where I live or the type of practice I've had. I've had an amazing number of discussions with patients already. Ironically, I mean, the bill passed on Tuesday. I had 3 patients on Thursday ask me to give them their license. I said, well, we've got to wait till the rules are here. And I try to be open-minded. You know, what do you need it for? You'd be amazed. You know, my left arm's numb. You know, and, you know, right now, marijuana is, you talk about anecdotal stories. You know, you hear people, hey, this is going to help everything from headaches to hemorrhoids, from toothaches to ingrown toenails, and everything in between. Well, I'm going to be open-minded. I'm going to say, bring me some scientific studies, some scientific evidence that this is effective for what you're telling me you need it for, and then we can have a discussion.
And so I've had concern, too, about the 2-year license with no required follow-ups. I mean, I brought that up in this meeting. But it's been presented to this committee that this is a 30-day, the possession limits are a 30-day prescription, not prescription, recommendation, and the limits allowed by law are 30 days worth of supply. So I guess you would rather see that your patients would follow up with you after every 30 days or something like that, similar to what they would do with what?
Well, probably initially, after the patient's been on therapy for about 4 weeks, we would like to see them and see how they're doing. Yes, I mean, that's not atypical with patients that are treated for depression and they're placed on an antidepressant. Antidepressants take about 2.5 to 3 weeks before they have a adequate steady state in the individual before we see any changes. There's several other medications that we treat patients with that also require extended amounts of time for them to reach steady state, so we can see how the patient's responding. Certainly, it would be something that, yeah, if the patient had a month's worth of therapy, let's have you come back and see us and tell you how you're doing. You know, if it's something that's positive, all the better. If it's something that you're having problems with, we need to know that too. It's like I said, this is not, you know, it's not a benign substance. just because it's being treated as a nutraceutical right now. But it also is not a substance that is going to have, it's like everything else. The majority of the time, it's not one extreme, it's not the other that we're faced with, it's something in the middle. And we would like to simply have the ability to help patients that want to be helped through their therapy. And I think the patients that truly are our established patients, that are a physician's established patients, are going to come back and say, you know, listen, I'm really glad I got the, you know, or I haven't received any benefit, 1 iota from this. What do we do next? So a lot of the onus is not necessarily, it's strictly whether or not you reappear is up to you as the patient in the end. And it would be nice if you did come back and see your physician after you've, like you said, after you've been under this therapy, because it would help us know what the end point is and whether or not you have received some benefit, and if more, and like I said, the other thing is if you're having problems.
Final follow-up. So, but I want to just be clear in this room today. You don't believe that the legislature, you control those follow-up appointments. You don't want the legislature legislating how you interact with your patients. Is that correct?
No, the physician-patient relationship should be outside of, you know, it shouldn't be something that's mandated by the government. It ought to be something that in the common sense world is something that the physician and the patient are supposed to arrive at on their own. And because, you know, a great deal of therapy that whether it's medicinal or other types of therapy that patients receive, there has to be a healthy discourse between the physician and the patient for the therapy to be successful. The more the physician knows about how the patient's doing, the better off we're able to help them. The patients aren't on an island by themselves, and we shouldn't be either.
Thank you.
Representative Copeland.
Thank you, Mr. Chairman. I have a very simple question for you gentlemen. The bill says that you have to have a doctor-patient relationship, and to get the signature for your license, has to be a doctor. If your family care physician happens to be a PA, would either of you have any opposition to a PA being able to sign that?
I think the way the law is constructed is from the standpoint of it needs to be a licensed physician, MD or DO in the state of Oklahoma, and I don't think that should be changed. I think that does provide what limited amount of oversight that needs to be done. So no, I'm not in favor of what you were referring to as physician extenders being in the prescriptive process for this, or being in the licensing process for this. It's not prescriptive, but being in the licensing process.
Dr. Cox?
I would agree. To me, it follows along the way I treat Schedule IIs. I have no qualms with physician extenders being able to write a short 1 to 2 week prescription, which they can't do now, for Schedule IIs, but I oppose unlimited prescribing authority. Since we're talking about a license that, as I understand it, has a 2-year lifespan, I would prefer to leave that to the licensed physicians.
Senator Yak.
Thank you, Mr. Chairman. Doctors, thanks for being here. Dr. Cox, it's good to have you back at the Capitol. I can tell you really miss this place, right? You don't have to answer that. That's not my question. Dr. Mullins, you mentioned you're also a graduate of the pharmacy school at OU. I don't know how long ago that's been, but I assume their grads, as well as Southwestern's pharmacy school grads, go to other states that have medical marijuana. I'm curious if in those curriculums, if they address any type of this sort of drug, I don't know how you would qualify it, just medical marijuana, if they have any training, or they provide any training for those pharmacists going out of state.
I'm not sure. I graduated 37 years ago from OU, so You know, I remember discussing in pharmacology the cannabinoids. That was something that came up. But as far as specific training, no, I don't know. I honestly don't know. And in fact, there's so many other things that have to prepare graduates for, that are something that they are dealing with on something that they're going to be dispensing through their own pharmacies, how they talk to patients about their therapy, and how they counsel patients with the result with patients anymore don't have one or two items that they're taking. They have a laundry list, it seems. And the pharmacist a lot of times is being asked to be the sort of the last line of safety in the physician patient pharmacist relationship, because they are the ones seeing the entire profile sometimes, and they know what interactions are occurring. Certainly, that's going to be something that is being it was discussed when I was there, but it's certainly not as important as it is now. And I'm certain that they're ramping up their curriculum now to, I haven't discussed it, haven't talked to them, but I'm certain they're going to be ramping up their curriculum to include this. And it's necessary. Now, whether or not that you will ever see a member of a pharmacy team in a dispensary is probably something that I honestly don't think it's necessary at this point, because what can they discuss? They're bounded by the same federal laws that we are.
Thank you, Mr. Chairman. Yeah, and thank you for that answer. Go ahead, Dr. Cox.
I also have not spoke with any physicians from states that prescribe marijuana, but part of the reason I made my prediction on my 10-year projection on outflow versus income is what I'm beginning to hear from those states, and I would encourage you, and you may have already done this at some of these committee meetings, is to visit with the law enforcement officers, the DOC officials, and the social workers from those states, and get an idea of some of the problems they're beginning to see.
And maybe that part of the answer to this question, I assume through your associations maybe, or through your continuing ed, you associate with other doctors from other states where this is already where it's already legal. I'm just wondering, Dr. Mullins, you talked about the federal conflict, how they jive that by, I don't know if they're prescribing drugs, what their law requires, or if they're just signing an application like we are in Oklahoma, but how they balance that, because they're in the same federal restrictions as we would be in Oklahoma.
I actually don't know the answer to that. I will not be a registered provider for this in the state of Oklahoma. It just is not within the scope of, I practice hospital-based medicine, and I'm not a subspecialist in pain control like three of my partners are. We are going to see this impact our practice in anesthesia, because we're going to have people, and we already do have people that come in that are using marijuana. That's nothing new. That has never been anything new. But it is going to impact our practice some. And honestly, I've not discussed with any of the prescribing physicians in any of the other states. There are some, as Dr. Cox said, there is some data from the mental health agencies in California and Colorado, specifically about some of the issues that they're having. There is a fair amount of data that's in the with adolescents and young adults that's appearing in the substance abuse literature and peer-reviewed journals that addresses some of the effects of early cannabinoid use, early cannabinol use. And those are extremes, and they do affect a small amount of that population. It doesn't appear to be as much of a problem past the age of 25, but certainly in some in young individuals between the ages of 18 to 25, there is a window that with brain development, and this has been very well described, like I said, in some of the peer-reviewed journals. It's not a large population in that group, maybe 10 to 15% that have some issues, but it still isn't, when you meet out the numbers, that's quite a few folks in the long run. But those are some issues that I think will have to be addressed at some other point, and I think that we will see them in the state of Oklahoma. What the numbers are, I don't know.
Final follow-up, Mr. Chairman.
Final follow-up,
Thank you. Dr. Cox, if you'd address this, if you don't mind, and maybe you touched on it a little bit. The section of the law, 7088, that is specific, talks about there will be no qualifying conditions. In that same paragraph of the law, it refers to Oklahoma board certified physicians or who would be asked to sign this application. So that term is pretty broad, Oklahoma board certified physicians. So if you would address your thoughts on whether or not that should be tightened up. And also, I think you talked a little bit about the monitoring program that we have now for opioids. If something like that is made a recommendation from this committee, should that monitoring, should that fall in the responsibility of the doctor? Or where should that be? Should it be at the retailer, or maybe your thoughts on that as well?
That's a good question. I really haven't thought of that. I suppose, just like our PMP for opioids, the monitoring is at the source where they get access to opioids, which is a physician. If we're talking about a 2-year license, a 2-year window, then perhaps the monitoring source should be at the dispensaries. So they can monitor how much someone is getting through the dispensaries, because the physician really is not going to have any way of knowing that, as I understand the legislation as it's written now. As far as board certified physicians, there are some physicians that are not board certified. The majority of them are. I would say a licensed physician would be the main thing. And I think it would be up to the individual physician. I haven't made a decision yet on whether I will be writing the license or not, but I can tell you, as I've alluded to, if I do, I'm going to only write it for conditions where there's scientific proof that it's effective for, rather than going on hearsays like, oh, my friend has anxiety and he does a lot better with mood-altering forms of marijuana. Well, probably so, but I want to see some scientific evidence of cost versus benefit versus side effects.
Representative Loring.
Thank you, Mr. Chair. In the language of 788, when it talks about the standards that the doctors are to use, it uses the language, according to the accepted standards, a reasonable and prudent physician would follow. Now, with my legal background, those are terms that we use, but in the real world, does that give a doctor any real guidance of what they're to be looking at?
I would say it leaves it pretty wide open. The main guiding rule is first do no harm. And I would look at that as probably that, because there, again, as my colleague alluded to, because of it being a Schedule I, there hasn't been much research on this. So we're kind of going down a blind alley. And that's a little bit worrisome. And that's one of the things I'm going to be weighing on when I decide whether or not I'm going to be a provider of a marijuana license is, hey, there may just not be enough studies and evidence here yet because it hasn't been allowed for me to be willing to accept the liability to go down that path. But I agree with you, it leaves it pretty wide open as it's written, other than do no harm.
Honestly, the term standard of care really doesn't give us any guidance whatsoever, because that's, like you said, it's a fairly broad statement, and I appreciate that. I'm married to an attorney, and and she is a wordsmith, and it is something that that when she read that, she looked at me and said the very same thing you said. What does this mean to you? And it doesn't mean anything to me. Standard of care is just a three-word phrase there, and it's left to wide open interpretation.
Follow up.
Thank you. So Since Dr. Cox brought up the issue of liability, one of the subjects that we never talked about in our conversations in the past was medical malpractice. My concern is, and we all understand that at some point in time, the legal community is going to catch up with reality again, and there's going to be litigation against doctors alleging that the doctor violated this standard that's set out in 788. But my concern is, because marijuana, at least at present, is federally illegal, does medical malpractice cover a doctor for an alleged violation of these standards for something that's federally illegal?
I think that's a legal question rather than a medical question, but I will tell you that what has gotten physicians' attention with opioids was not my PMP bill. It's the fact that a doctor whose patient dies of an overdose can be charged with manslaughter now and is being charged with manslaughter. Well, we're going to see the same thing. I grant a marijuana license to someone. They get high on marijuana, cross over the center line, and hit a van full of kids from a daycare center. Am I going to be charged with manslaughter? I think that's a realistic question, given what we're seeing with the opioids. Wouldn't you agree?
I think the issue of liability here is something that's going to be, that's something that is going to be determined by the plaintiff's attorneys, the plaintiff's bar, and also the defendant's attorneys in the long run. This is you're right, this is an inevitable question. And that's probably, honestly, it's enough of a question for me not to become a provider.
Follow up?
Thank you. So, in all due respect, Dr. Cox, I'm not so concerned about you being prosecuted. What I'm concerned about is the injuries to that busload of daycare kids. Are they going to be receive any recompense for the injuries if, in fact, somebody can show that the doctor violated these standards in signing off on that particular individual's license?
That's a good question. And I'm sure physicians are wondering the same thing.
Final follow-up.
One of the things that you discussed, I'm changing subjects here a little bit. You talked about in a dispensary level equivalent of the PMP program. But that in no way takes into consideration the home grow operation and how that affects the entire scenario of everything we're talking about. Is that correct?
That would be correct.
We have two more in the queue. Senator Daniels.
Thank you, Mr. Chairman. I've not yet spoken with a physician who plans to participate. They've raised questions as you have today, but you started out saying that because it's a class 1 that you wouldn't discuss it with a patient at all, but then as our conversation evolved, you did talk about speaking with a patient about it. So I need some clarification on that. I'm concerned about the people who do believe they will benefit from medical marijuana, constituents who've called me who that is their motivation. So I'm trying to focus on them. If they're an established patient of yours and they're on other prescription drugs, whether you like it or not, aren't you going to caution or talk with them about the possible interactions? But if you do, and something befalls them from their use of marijuana that they get at a dispensary and you didn't write a prescription and you have no idea what form they're taking, it still comes back to, I don't even know how you have that conversation with an established doctor-patient relationship. It's not really a question. I'm just troubled by the whole attempt to actually give good advice to a patient who might benefit, and they're your established patient, and I don't see a way out of it.
Well, it is very difficult. For instance, when I prescribed Schedule II narcotics, the patient had to sign a pain management contract that stated that they would be subjected to, at my request, any time when they come in, a drug test. And an amazing number of those people we no longer see, because when they said that, well, we don't take anything other than what you give us, they would test positive for THC, they would test positive for methadone, they'd test positive for benzos, other controlled substances that they would deny. So that was one of the tools we used to monitor patients, and I'm sure that physicians will continue to use drug screens in people that they write marijuana licenses for.
Representative Rosecrans.
Well, thank you, doctors, for coming in today. A lot of the questions have been answered, so thank you for being so forthcoming. But I do have a few other questions. First of all, given that, Dr. Cox, that you have agreed that THC is a medical component of Marinol, and that this study has shown that CBD is an effective medicine, are you saying that the combination of those cannabinoids isn't medically effective?
I'm saying at this time, I have no qualms about the non-mood altering, non-psychotropic components, extracts of marijuana. My concern is because it's the mood alteration that leads to addiction, and the desire to get better mood alterations that may lead to different substances. That is my concern.
Follow up.
Follow up.
And I understand why you would be. I think a lot of times, if you don't mind me taking the time to say this, it's just a matter of getting past some of the old thoughts. You spoke about anecdotes, or just like how anecdotal evidence and stories and things like that. I think some of that also is on the other side of it too, kind of like the lazy stoner on the couch, things like that. I'm becoming a believer in this as a medicine, just from things that have happened in my past. My mother passed away recently, and she was ravaged by opioids, and she moved to Colorado and was out of pain for the last few years. So I'm kind of new to this, and I do a lot of research. And also, I really care about low-income people with disabilities, those types of things. And I know that as I did some research, Marinol and this new one, Epidiolex, that one is extremely expensive. I think it's up to $5,000. So my question is, wouldn't you agree that it's important to treat patients, or at least have the treatment to have access to the health benefits of cannabis, as in State Question 788? Open to both of y'all.
I would say, as a physician who cares for many hospice patients, we have some excellent treatments for pain, everything from fentanyl patches, liquid morphine, morphine extended release, diazepams for anxiety, all of which have side effects and addictive potential. But I really haven't found a patient that we couldn't do a fairly good job with the arsenal that we already have. I mean, it may take higher doses than you expect. It may take different combinations than you expect. I fear opening up another Pandora's box without having a better way of controlling the milligrams, how much, how often, the things that, to me, the medicinal medicines, and I'm not opposed to alternative medicines, but I am opposed to alternative medicines with the potential side effects and societal problems that I see with this.
I think you brought up a very nice point about end-of-life issues, and certainly making people comfortable at the end of life is most of the time is about all you can do. The treatment of the disease is well beyond the scope of trying to you're simply taking care of the patient, trying to make their end of life as comfortable as possible. Cannabinoids definitely probably will have a therapeutic advantage because of, and depending on which one you use, of course, but you know, the three that are currently recognized by the federal government are just very limited in the spectrum. The Marinol, or dronabinol is the generic term, is actually a synthetic compound that's not from God, I can't even talk this morning. It's not cannabis derived. It's a synthetic compound that mimics THC. And it certainly has been found in some patients to be beneficial in chemotherapy-induced nausea and also in stimulating appetite. That's pretty much all it's related to. There's another compound that's used for emesis in patients that have chemo that strictly is addressing one specific receptor in the brain. Yeah, Epidiolex is yet, I think, actually to hit the market. It was released in June of 2018 by the FDA. It is going to be prohibitively expensive, and there is probably going to have to be some type of programs available to, and the drug manufacturers a lot of times help with cost, but you know, they're not going to bear the entire cost. But there are some. It's nice because it's indicated in a very narrow area for these and seizure disorders, and it may, as Representative Eccles alluded, be more beneficial in some of the other seizure disorders as time allows us. But the use of cannabinoids and cannabinols in the treatment of end-of-life issues is something that I think in the future may honestly be very beneficial to these patients. It's just that we have no specific experience currently with it.
Thank you, gentlemen.
Thank you very much. I see no more in the queue, and so we will be taking a break. Before we take the break, I want to thank you guys for being here. I know doctors get paid for seeing patients, not for coming to the Capitol and talking to us, so I appreciate you taking the time to be here. I also want to briefly, I guess, prepare us for the public comment period, and so I have the list of people, or at least the first page of the list of people who have signed up to speak. I would like to call the first 6 people who are on the list. For those of you whose names I call, if you would meet one of the sergeants, which is the guys in the red coats, will meet you over in this corner to begin kind of getting us ready to go into that. Our goal will be to move through and to have as many people speak as possible during this time. And so we will, again, we'll take a break before we get started. But for these 6, if you would meet the sergeant over in this corner, and some of your handwriting is as good as mine, so we'll try our best to, so Chelsea Kennedy, Ron Marlette, John Pettyjohn, Andrew Vinnick, Sarah Willauer, and Leslie Collum. If you 6 would come over here and they'll kind of talk to you about how we're going to move forward. With that, we will take a 10-minute break, so we will start again at 10:32. All right, thank you very much. We will be back in order. The way that we will do this, this is not a normal meeting whatsoever in this building, so let me attempt to give some boundaries, give some rules, and let everyone know from the top how we will handle this. Each speaker will have a maximum, and I want to emphasize maximum, of 5 minutes. There are more people signed up than we will be able to get to today. So if you only want to use one of your 5 minutes, there is someone else in this room that will be very thankful that you did that. If you only want to take the microphone and say, I agree with the person before me, that is okay too. You do not have to completely restate a position that has been stated already today. We're thankful that you're here. We're thankful that you signed up. We are looking forward to hearing from you, to hear your opinions, to hear the way that you look at the task that is in front of this committee and what we should do and the direction we should go. A few things that are not natural that all of us when we were elected had to learn is kind of the way that we operate in a meeting like this. And again, it's not normal that we allow public comment and allow so many people to take the floor. And so first and foremost, if you watch what we do either from the gallery or online, you will see that we do not ever address each other. You will address your comments to the chair, so to the two of us. Whatever it is that you need to say, please direct it to us. That keeps everyone from calling each other names and hopefully keeps people from making each other mad. So you can try to make us as mad as you would like, but you will not, and we never are in this room, permitted to address or call names or in any way denigrate someone else who is sitting in the room. We only speak to the chair and give our opinion to the chair. I can pretty well guarantee that as we move forward, someone is going to say something that will make everyone in this room mad. We do not boo, we do not clap, we do not do anything to interrupt, and in all honesty, for a whole lot of us, including one of the doctors that was here this morning, it's pretty intimidating to know that not only are a room full of people, but a whole bunch of people are watching you over the internet at home. Please, I ask that you do not do anything to break the concentration of the people presenting. They've made a big step to put their name on the list and to take a microphone today, and I hope that you will show them the respect that action warrants. We ask that you act with dignity. Foul language is not permitted, and as the chair, I do have the ability to cut anyone off for using foul language, for calling out other members, especially people who are in the room. Those things are not tolerated ever in this room during meetings. So with that, we are going to start. Mrs. Kennedy is going to give her testimony from her seat. Most people we will ask if you can, if at all possible, you would come to the podium here. Gives you the ability to talk directly to my co-chair and I. My partner over here is going to be our official timekeeper. He has a sheet that will tell you when you have 1 minute left. At the 5-minute mark, I will stop you even if you're in mid-sentence. We very much want to hear from as many people as possible, and so I will be as strict as I possibly can on the 5-minute timeline. With that, I will turn the microphone over to Ms. Kennedy, and your 5 minutes have started, and thank you very much for being here.
Thank you for allowing me this opportunity to speak to all of you. Through this process, I have been extremely impressed by this committee and their dedication to support the will of the voters. My name is Chelsea Marlette Kennedy, and in 2017, I helped found Patients and Activists for 788. After working through all of the other petitions and working very hard. We are a patient-based organization seeking to advocate for patients. We feel that most of the plans presented here are good for patients. However, we do have some concerns. We are deeply concerned about any language that would limit the number of dispensaries. A free market approach lowers the cost of medicine for everyone, and many patients are struggling to make ends meet as it is. We are concerned about allowing municipalities to decide the locations and hours of dispensaries. It's already happening in places like Yukon and Cushing, making it extremely difficult to find a location in which a dispensary would be allowed. Medical centers and pharmacies do not face these sorts of regulations, and these sorts of regulations should not be put against medicinal cannabis. This would prevent patients who often struggle with transportation from having access entirely. We would like to see a low-income program implemented by dispensaries wherever possible. Cannabis is expensive and insurance does not cover it. A friend of mine, Chris Molsness, who unfortunately could not make it today, has already designed one for veterans, and we'd like to see it implemented for low-income patients statewide. Many patients will not be able to afford this life-changing medicine without it. We would like to see a patient advocacy department of the Oklahoma Medical Marijuana Authority, preferably directed by patients. This department would serve as a protection for patients in the event that they have negative outcomes as a result of poor quality product. You now have the opportunity to help craft a program that benefits the people, that eases suffering, and allows for opportunity. We can show the nation, once again, what the Oklahoma standard looks like. Thank you.
Thank you very much. Mr. Marlette, if you would like to take the podium. I appreciate you being here, and your 5 minutes have begun.
Mr. Chairman, Mr. Co-Chairman, thank you so much for allowing me the opportunity to speak today. My name is Ron Marlette. I'm a clinical social worker here in Oklahoma City. I've been practicing for 42 years. That work has been in mental health. I work closely with physicians and psychiatrists over that time. I have had extensive experience in treating Vietnam veterans with combat-related PTSD. Over the past 15 years, I have visited residents in nursing homes. It's estimated that 22 veterans commit suicide every day. And unfortunately, due to federal law, physicians are hamstrung as to how they can treat. Predominantly, veterans with chronic pain are treated with opioids, and with PTSD, they're treated with the substances called benzodiazepines, such as Valium or Xanax. Both of these substances are addictive or potentially addictive. Earlier, Dr. Cox expressed concern about the use of any substance that alters moods. And I would remind the committee that antidepressants alter moods. I sure hope that they would. Benzodiazepines alter moods. They reduce anxiety. I would hope that. I asked Dr. Cox if a person was in a mood where they wanted to harm someone or someone else, if it would be helpful that we could alter their mood, and he agreed that it would. There was so much concern expressed about mood-altering substances, and I thought, well, if there's that much concern looking at alcohol being the #1 abused substance, maybe we should remove alcohol from liquor if we're that concerned about mood-altering substances. There was also a great deal of talk about the fact that there's no research available. That's simply not true. There's an immense amount of research that has come out of Israel. There is a doctor there who named Raphael McCullum, who basically rediscovered the endocannabinoid system. That system is represented in this photograph. This system has been in the human body forever, which would suggest to me that human beings have had a relationship with cannabis for as long as human beings have been on the planet. Otherwise, I'm not sure how that system got in the human body. We know that we need to do something to help our veterans. We owe them that. We know that we owe the greatest generation in America far better than they're usually given. It is my hope that we see to it that nursing homes follow the law, allow their residents to get cards if needed, and that nursing homes are allowed to administer cannabis as they see fit. Many nursing homes are very concerned about smokable marijuana, and I think that the use of oils and edibles will address those concerns. As a social worker, it's my concern and my passion that my clients have access to every resource that can help them cope more effectively. I'm very excited about this legislation, and again want to thank you for the opportunity to come and speak with you today.
Thank you very much, and great job with the time.
Any questions?
Thank you very much. We would never get done if we stopped for questions. Mr. Vinnick, and one thing I've thought that, so this meeting is scheduled to end at 11:30. So I wanted everybody to know that beforehand so no one gets, mad when they're the next person in line, but we don't get there. Also, if the speakers, if you guys would introduce yourselves when you get up so that I know there are members of the press and people watching from home who would like to know the names of the people that they're reporting on. So with that,
Sure,
your 5 minutes begin. Thank you.
Well, committee members, thank you so much for having us today. Mr. Chairman, Mr. Co-Chairman, thank you as well. My name is Andrew Vinnick. Come from the state of Colorado. I have no interest in cannabis here beyond the black market, and I will explain that as I continue. We operate 30,600 plants in Colorado under 138,000 square feet of light deprivation greenhouse. And what we've seen in the Colorado market, and which I will speak to here in my concern for oversaturation of licenses, is a destruction of the commodity price. At the greenhouse level and outdoor level, you're able to produce cannabis at a much lower price than you are indoor cannabis. And the concern with having too many licenses in the market is that that commodity price is then reduced, obviously making it more easier for patients to acquire in terms of price, but for the producer, you create a situation where you would be selling at or too near or below your cost of production. And that becomes massively important when you consider that we're still taxed under Federal Code 280E, which does not allow us to deduct anything below cost of goods sold. So SG&A, none of that's deductible. We're taxed at top line revenue. And what you'll see here is that if you allow that commodity price to decrease because of oversaturation of licenses, you'll end up with a situation where you have fine men and women who are trying to get into this industry and make it succeed, where they're having to pull strings, potentially divert product to the black market because of oversaturation, because they're not able to make up on their taxes what they would ultimately either have to not pay or pay little of in terms of bottom line profit. You could, and we've seen it in Colorado, have dispensary owners and cultivators who have brought zero or negative numbers down to their bottom line and still owe taxes. And this is then where the IRS comes or local authorities come and lean on these individuals. There's no bankruptcy protection in cannabis either. It's a federal protection. It's a protection that cannabis cultivators and store owners will have to forego by entering into this market. I know education is a paramount piece to Oklahoma and something that's discussed often. There's an example just up the road from a couple of our facilities in Colorado is a lady whose husband entered the Colorado cannabis market, and he unfortunately passed, leaving on the company to her. She's a school teacher, and because of her inability to file for bankruptcy, because of 280E and that being a federal protection rather than something that cannabis consumers, or excuse me, cannabis producers can access, has had to go through her life savings to just maintain the business and wait out trying to find a buyer. Because of that oversaturation of available licenses in Colorado, she's yet to find a bidder, and you're seeing a tremendous amount of investment that was in Colorado because it was exciting, because they thought it was a massive profit center, cannabis, realized that no, we can't really make money, at least efficiently, unless we were to take it public in Canadian markets or something like that, which then becomes another element for you all to consider. You expand that a little bit and look at Oregon or Washington State, and you have even more saturation of cannabis product in those markets, and where you're seeing now commodity prices well below the $200 mark in those states, which is massively problematic for producers. And then, again, leading back to, are they getting leaned on by the IRS or by local authorities? Where are they going to find the money to recoup and pay those taxes? And that's where the concern from an outside resident and or a resident of the United States, but outside of the state of Oklahoma, but also someone who participates in cannabis and is concerned about this in our own state, is that diversion will occur to the black market as a means to make up the what was lost and what needs to be paid back to the government, so you're not having these situations where you're getting leaned upon. I think this is a paramount thing for you all to consider, especially as you look to protect the citizens of Oklahoma, as well as the citizens of the United States, by virtue of you all taking this enormous step forward in legislation and in how the United States is perceiving cannabis. Thank you so much.
Thank you very much. I'm Sarah Winauer. I hope I'm at least coming close on some of your names. Well, it looks like Will Hour, but yeah. Thank you very much, and your 5 minutes of start.
Thank you. Sarah Willauer. I came and wrote my name on the list because I'd rather have it on the list and want to say something than not have it on the list and want to say something. So I wrote this just a few minutes ago. I'm just a regular citizen that has followed medical marijuana across the country over the last 5 or 6 years, and I've researched very extensively all aspects of medical marijuana, the businesses, the patients, all aspects. Before the vote on 788, I read Senate Bill 1120 and House Bill 3468. I have family and friends that have been affected by addiction in the opioid crisis, and I've followed research on medical marijuana and helping people withdraw from opioids. I'm interested in every side of this industry, but the research side of this industry is where my heart is. I want to help people. I want to find the potential I know exists in this plant to heal people and prevent illness and injury. I feel like doctors have taken a wrong turn at some point, and I know they're not here, but their job is to first do no harm. And you know, they stand up here and talk about synthetic THC products and synthetic CBD products and say, you know, that they helped pass a bill approving their use, but they have a problem with the whole plant of medical marijuana, and that makes absolutely zero sense to me. Doctors in the state need to start preventing illness and teaching their patients how to be healthy and how to prevent illness through diet and natural supplements. It's common sense that the natural form of a chemical is safer than the synthetic form. I mean, you don't have to have a degree to know that. We have a war veteran that came to speak. I was standing outside with him before the doors opened. He came straight in and signed his name on the paper, and he left with his walker, keep in mind. Because you could tell he was so frustrated by what he was hearing from the doctors. He got up and left and didn't have his voice heard here today. We have veterans that want the ability to try medical marijuana to attempt to get off some of the FDA-approved medications that one of the previous speakers spoke about. These medications are killing people. We have veterans and children dying from drugs that are approved by the FDA. We have children that are overdosing on things simple as Tylenol. We have baby food that's testing high in heavy metals. The FDA can't be trusted to do their job. They're approving things that aren't safe. The Oklahoma legislature, I implore you to call a special session and approve the unity bill that the leaders of the medical marijuana movement worked so hard to get finished. It isn't perfect, and there are things that can be addressed later if need be, but we owe it to the citizens and the voters of Oklahoma to do what we have asked of you. You had the opportunity to pass legislation for medical marijuana before June 26th. You didn't take that opportunity, and due to that failure, you're in the position where you have no other choice than to pass legislation that is in the spirit of 788, so that businesses can begin to grow and get product to dispensaries, and patients have access to a safe product that has been tested for pesticides and other components. Oh, I have my time run out? I wasn't paying attention.
No.
Oh. Sorry. So, anyway, so that start growing and patients can start to get their medicine, and we want patients to have access to safe, pesticide-free products. They need to be tested. We know the Department of Health has already come out and said that they can't regulate, they don't have the ability to regulate. They're concerned about their ability to regulate. What are we going to do whenever business licenses start going in on Saturday, and then what? Businesses start opening, people start growing. Somebody comes in and opens a 150,000 square foot cultivation facility, and then whenever legislature comes back in session, they say, oh, there's a 20,000 cap. Well, then what's that person going to do with all their investment that they have and all of that? This has to be addressed before businesses start opening, before any of this happens. And I would suggest that you address that through a special session and voting to approve the Unity proposal. Thank you for your time.
Thank you very much. Before we call up, we have one more in the queue. I want to go ahead and the next 6, you guys don't need to get up and move yet, but I just want you to be prepared so that we can transition through the first group to group number 2. So that the next 6 after, again, no need to move yet, Marcus Ray, Lawrence Pasternak, oh man, Willoughby is the last name, first name starts with a D, Jubal Barrett, and Gordon Flick. So, but first we have Leslie Cullum. So if you'd like to come take the podium and tell me how I should have said your last name, that would be great. Thank you very much for being here.
Hi, thank you for letting me speak today. My name is Leslie Cullum. I've been a registered nurse for the last 15 years. I've done emergency room nursing, also an RN case manager. Actually licensed in 40 states, so I do most of my work in the Northeast. We see a lot of medical marijuana being recommended there. I feel like we definitely have some... Am I? Okay, I'm on.
We're bringing you a new and we have paused your time, so.
Okay, am I good now?
Hopefully.
Okay, I've also been a medical activist for cannabis for the last couple of years, and really I didn't start on this because of my nursing, but because of my daughter, and my mom had stage 4 metastatic breast cancer. She used cannabis butter, put it on toast, help with the nausea, help with the pain. It's probably the only thing that gave her an appetite, allowed her to eat. Otherwise, she laid in bed, miserable, nothing by mouth. I feel like it helped her move through her process and allow her to die with some peace and some dignity. We've heard a lot of the doctors report that there's opiates and benzos, which are FDA approved, and they're killing people. Medical marijuana does not kill people. There's plenty of research that shows medical marijuana helps with a variety of symptoms, a variety of conditions. Patients report that it does, and we owe our patients that legal access to medical cannabis when it's recommended by a medical provider. Probably my biggest issues that I'm having that I don't feel like we addressed is patient access, like ease of access. For instance, we have a place at Lake Texoma, and I know everybody in Durant, which Durant, it's fairly large. Everybody in Durant, there's no medical provider there that they can go to get the recommendation. So now we've got lots of vulnerable patients that are in these, rural areas that are having to drive 2 hours plus to get that medical recommendation. What if they have no transportation? What if they can't get out of bed hardly? I mean, how do we expect them to travel all the way to the city? What if their financial resources are strapped? They can't get to the city. What if they don't have family? What if they don't have friends? That's not uncommon for an older vet, an older patient. That's not uncommon at all. So these people are left behind. And then another issue I have is the fact that we aren't allowing for any delivery to any of these patients. When we have bedbound patients, when we have terminal patients, let's just say it happens to be a day, it was my day to go get my medical cannabis, and I woke up and I can't get out of bed. My symptoms are so terrible today. What are they supposed to do if they don't have a caregiver in that option? So I would propose that as far as the rural areas in providing the medical recommendation, maybe we really do need to think about allowing nurse practitioners, physician's assistants, other people rather than just doctors to recommend medical cannabis. It's not a prescription, it's a recommendation. It doesn't require a physician. It really shouldn't. But, and then the follow-up every 2 years. Well, I go to my PCP once a year to get my prescriptions refilled. Otherwise, I never see them because I'm so busy with my other doctors. So I never see them. And I believe as far as the delivery, we need to issue some special transport licenses, whether it be medical professionals, a designated dispensary agent. Somehow, some way, we've got to allow for special transport licenses that are not going to be at the cost of the patient and will be at the cost of the person with the special transport license, and also won't limit them to those 3 ounces. If I'm a nurse and I'm delivering to 20 patients in Durant that can't get to a dispensary, I'm not going to drive back and forth to get them their 3 ounce of product and then go and pick up another 3 ounces for the next patient. Thank you very much for your time.
Thank you very much. All right, the 6 people that I called earlier, if you're not already sitting in these front 6 seats, if you could make your way up and take one of those seats, that way it's easier to transition between speakers. So that would be Marcus Ray, Lawrence Pasternak, Willoughby, Barrett, Flick. Oh, and I'm sorry, and Ray Jennings. All right, so Marcus Ray. I
told him he could speak for Petty John. He's with the same group. That's my fault.
Okay.
No, you're chairman today.
Are you on the list already? Okay, let's wait until you come up on the list then.
It's my problem next week.
I'd like to point out that's all my co-chair's fault right there. Marcus Ray.
Thank you, Mr. Chairman.
If you could, I'm sorry, you got a knee brace on, gotcha.
Well, I pulled it off, but it still hurts a little.
I've seen you limping around, so absolutely
Thank you,
go
sir.
from there. Thank you.
I really don't have a lot to say as far as the law or what we're going to do. I think there's a lot of people working for the law, for the patients. I just want to extend my gratitude to the committee, the working group, you gentlemen as the chairman, for what you've done to make sure that we do keep things moving. I was just going to say, I don't know if anybody's kind of following. In Ohio, they've been working since 2016 on their law, and they still are looking like they're going to miss their deadline for this fall. And I think what we're doing in such a short period of time is nothing short of a miracle. And everybody's doing a great job. So that's kind of about the gist of it. In generality, I think a lot of the questions and problems that some of the people that remain opposed to this, be it doctors, law enforcement, is there are going to have to be some federal changes. That's what we need to primarily emphasize on, that it's not our state to do that, to make federal changes. It is the federal government. It is the United States senators, the congressmen. It's up to them to do that. And so many people, they get mad, but they don't know who to be mad at. And I think at the core of the lack of cannabis research is mainly around the federal government's lack of commitment. Just some quick numbers here. In 2017, the DEA had 1,040 pounds of cannabis produced for research purposes. 2018, they first projected 978 pounds would be satisfactory, and now they're going to claim that they're wanting 2,500 pounds is what the demand is up to. I don't know if that has to do with what the FDA is doing with the $5,000 a month drug or whatever. That's neither here nor there, but now they're wanting 5,400 pounds in 19. So I do think that the demand has increased for the federal government to look at this as a good alternative, a cheaper alternative, and albeit more effective. And once again, the working group members, you guys have come in here in your time off, and I think you guys are doing a great job.
Thank you very much. Lawrence Pasternak.
Thank you for this opportunity to speak. Probably like many other people, I had very little understanding, knowledge of, or even really any interest in medical marijuana a year ago. I got curious, basically. I started to read. And I like to read. I read a lot. And I think that over the last 6 months in particular, I've gained a pretty broad understanding of everything ranging from the pharmacology, the botany of the plant, the epidemiology related to its legalization. And I've been speaking about this issue for a while, op-eds in newspapers, talking with people. And one of the concerns that I have is I just feel that a lot of the medical community isn't reading as much as I am. And I'm not a physician. I'm a doctor of a different sort of a PhD, but not an MD. I don't practice medicine. And there are certainly doctors in this state that are reading. My primary care doctor, I believe, is, and there are doctors that are opening medical marijuana practices, of course. But there's, I just did a search last night on PubMed. There's 18,000 citations to works on cannabis. There's 28,000 citations to works on marijuana. And hardly, of course, have I or anybody else read all of these. But I've read probably a few hundred of them. And just a few things I could point out, maybe to speak to some of the issues of the physicians that were here earlier. Dr. Mullins indicated that he's not able to discuss marijuana with patients. Well, there's actually a Ninth Circuit Court decision, 2003, that recognizes that physicians are First Amendment protected to be able to discuss marijuana, or pretty much anything else for that matter, with their patients. They can't prescribe it. However, they could discuss whatever they'd like to with regards to marijuana. So physicians can be educated and can have those informed discussions with patients. There's nothing that's preventing them legally from doing so. With regards to Dr. Cox, one of my concerns was that he indicated that he supported Marinol's legalization in the state because it was not psychoactive. But Marinol is a synthetic form of THC. It binds to the same receptors. And if you were to just look at a prescription insert, if you were to just to Google Marinol, you will find a list of psychological effects, including everything from euphoria to anxiety to somnolence. It has the same profile as THC. Marinol basically effectively has the same effect as purified THC on individuals. The difference is it's made in a lab as opposed to made in a plant. Well, now the question is there any benefit to the plant form? And one concern that I have is that if, for instance, I think it was the July 10th version of the Department of Health regulations, where they were going to ban smokable versions and allow edibles. One of the problems with edibles, with purified THC edibles in particular, is that it doesn't go along with, it doesn't include CBD, doesn't include the terpenes that modulate the effect of the THC. And so THC on its own causes more extreme psychological effects than when it's moderated by CBD, when it's moderated by terpenes. So the physicians, I suppose, who are promoting THC edibles were actually promoting something that was less good for a patient. Let me add to that the edible form of THC is metabolized through what's called first-pass metabolization through the liver. It converts into another molecule called 11-OH-THC, which is even more psychoactive than THC. So if a physician were interested in only allowing their patients to use edible forms of THC, they're actually going to get more psychoactivity out of that than the natural product, the product that would include CBD, include other cannabinoids, include terpenes. So my overall encouragement to the physicians of this state is read. There's a lot out there. Ethan Russo, for instance, is in my opinion, America's leading researcher in cannabis. He's an MD, and start with his work. There's a lot that's easily accessible through these wonderful little devices that we have in our hands called cell phones or in front of a laptop or a tablet. You can do it.
Thank you. Willoughby.
Good morning, everybody. How are y'all doing? Good. Thank you for your time. My name is Dranham Willoughby. I'm with the Oklahoma Veterans Collective for Cannabis. Sorry, I had to get that right. The speaker that was going to come up this morning had a health issue, so I'm going to fill in, and I hope I can get everything covered. But here we go. Sorry, I'm a little tall. Get away from the microphone. All right. Thousands of Oklahoman veterans are in crisis, struggling to afford medicine for their ailments, struggling for the medicine itself, and with the medicine itself, for that matter. Most of the veterans are uninsured or lack the benefits to receive a quality of life worth living. As you heard previously, a number 22 veterans a day commit suicide. We understand that. But what we're trying to do is medicate them on another level where they're not in pain, because they're substituting a temporary fix with the pain medication that they have now versus the actual medicine itself. Sorry, excuse me, I got lost in my reading here. Give me just a sec. For many of the vulnerable veterans, they rely on the state for help as well as the VA, whether it be the Veterans Center or outreach programs or otherwise. The state itself should take responsibility for the deep-seated issues facing the veterans today by keeping an open mind towards the potential solutions, including those involving cannabis. They can contribute. Sorry, this is notes from somebody else and I'm having to fill through. By keeping an open mind towards all potential solutions, including those involving the use of cannabis, they can contribute to bettering the lives of thousands of Oklahoma veterans as well. Now, with that being said, I'm going to throw a couple of numbers out there. There are almost 150,000 veterans registered with the VA in the state of Oklahoma. And about 1/3 of those veterans aren't even receiving any benefits whatsoever at all, whether it be housing assistance, medical, any whatsoever. So what our program is trying to do here, our team is working, excuse me, our team is working with researchers at the University of Oklahoma, as well as medical experts in the cannabis field, for the Veterans Collective to find avenues to conduct research into the effectiveness of cannabis for PTSD treatments, determining the current precipitation and usage of medical cannabis among the veterans, and to identify key veterans groups which to target, as well as work with anybody that would be willing to use us to find as the doctors were mentioning earlier, what is the word I'm looking for? I'm sorry. I hate to tie y'all up here. I know I'm wasting time.
You're doing great.
At wasting time? Thank you. Basically, we're trying to help as many of our veterans as we can. We all know that there's a problem there, whether it be financial, medical. A lot of them are suffering from health problems due to the medications. Right now, as of As of 2017, I believe the last number we had was a little over 46,000 veterans that have no help whatsoever at all. And we're trying to protect not only them, but the ones that do have benefits. I mean, we all are looking for a better quality of life, but we need your help on this one. All right, guys? Through the support of y'all, the legislators and the lawmakers in higher educational institutions, large veterans organizations, the Veterans Cannabis Collective, would like to be able to take the next step in helping deliver affordable as well as comparable medicines to everybody, not just veterans. But we are speaking for veterans in general. And with that, I will close. Thank you, guys.
Thank you very much. Mr. Barrett.
That's what happens when you have 30 minutes.
Hello, I'm Jubal Barrett, and I'd like to remind you, don't judge a book by its cover, because I know I look pretty with my mouth closed, but you know what's up. So, I would like to speak about the local license fees and restrictions. I don't think the local entities should be able to restrict local license. I think that we should limit the plant count. Like the individual spoke about earlier from Colorado, if everyone grows 30,000 plants apiece, then obviously we're going to have an issue, and then people's going to be selling out the back door. I've already discussed this with some of the members, and I've emailed the rest of them. But I would like to speak with the public about it. So with that said, I think if you limited 100 plants per license and 100 licenses per individual, you could regulate the amount of product on the market, and it would be less likely that anyone would deviate the product or divergence is what it's called, but you know, look at me. Okay, so second thing is if you do it by square footage, that doesn't really help anything, because you could take the Devon Tower, take all the floors out of the building and grow it a vertical grow to the top of the building, and then square footage wouldn't matter anymore. It's not square footage, but cubic, thank you, sir. Cubic feet that actually would limit the amount of space that was utilized. The next thing is, thank you for considering re-legalizing medical marijuana. And you're like, what are you talking about re-legalizing? Well, in 1934 in the Merck Manual, it was actually cannabis USP. The active constituent is cannabinol, an oily green liquid contained in the resinous exudate from the drug, hypnotic and analgesic, sedative, uses in turn in sedative mixtures for neuralgia, migraine, hysteria, neurasthenia, mental excitement. I get mental excitement personally. I get excited and I start getting going, you know what I'm saying? So obviously, if I had a joint in my pocket, I could bust it out and I could show you scientific evidence of how it cures that condition. But that would be not legal, but it would be lawful because it ain't against God or my God. But either way, that's not here nor there. So I would like to drop this book. I would just like to say that this is the Merck Manual from 1934, and this is pharmacopoeia before the federal government intervened with their Schedule I, which really didn't make sense since it was already a medicine. All right, so the next thing, jails and prisons. The guy was like, let's take a tour of a jail. Believe it or not, I've taken a tour of a jail from the inside. I faced life in prison at 20 years old. They say that they don't want to cause no harm. Well, if I would have smoked a pound of weed, what form of harm would it produce greater than me ruining my whole life, basically, to get in this position because someone else did something that I was unaware of? So that's another issue that's not here nor there. The other thing is, in the Beaubier's dictionary from 1934, if you look up jail, it says we have no prisons. We have no jails or prisons in 1934. So before we went to the federal rules and so forth, we didn't have the issue with crime that we have now. You can manufacture crime by writing laws. You get rid of laws, crime goes away. We make marijuana totally legal right now. All of a sudden, a bunch of people aren't criminals. We just reduce crime. I know, it's funny, but it's true. And the truth is funny, and that's what makes it funny. So, no laughing. You know the rules. So, like I said, in 1934, there's no prisons. Now we have the largest prison population on the planet. Me personally, I might do 2 years tomorrow for talking. This country's came to the point where you can't even speak without possibly being locked up. but that's neither here nor there. That's tomorrow somewhere else. So should we afford opportunities to promote new medicine to the sons of the men who outlawed the original medicine? I don't know. I really don't know. I don't know the answers to lots of these questions. I just know that the evidence presented may not have been in the purest light. And also, he says that we don't want to broker medicine. Well, legislation is brokering freedom. Lobbyists broker laws. Doctors broker medicine. Lawyers broker justice. Maybe the system is just brokered. You have a nice day. Thank you.
Thank you very much. Gordon Flick.
My name is Gordon Flick. I'm a 100% service-connected Vietnam-era veteran. I have no less than 5 providers at the VA, none of which are able to write me a recommendation. I've been using marijuana for over 40 years. I've also had no less than 6 opiate prescriptions all at the same time given to me by the VA. I suffer from a myriad of ailments. In 1997, I tried to be one of those 22 veterans that die every day. And since then, I found that if I use marijuana, it relieves almost all of my symptoms. I'm shaking here, I'm in great pain. I have anxiety, bipolar disorder. I have pain that runs through me. They say it's from nerves. And it was, I laughed out loud when that doctor said what he said about ingrown toenails, because I suffer from ingrown toenails. And when I take opioids, it does something that just, I can't leave them alone. And when I use marijuana, I don't have those feelings. I get very calm. I get very peaceful. My pain goes away. And the reason that I came up here to give you that side story, the basics, is because I don't have to pay sales tax in this state, thank you all. I don't have to pay property tax on my house. And once every 3 years, I don't have to pay ad valorem or excise tax on my car. And I think that everybody in this working group should consider, and I found this, I went to DPS for my wife. I was trying to get another disability placard, and one of the very astute employees at the counter noticed that I had a tax-exempt card in my wallet. She said, do you know that when you come here, all you have to show us is your 100% disability and we'll give you a placard? No doctor necessary. If anybody else wanted one, they'd have to go get a recommendation from a doctor to get a disability placard. As a 100% service-connected veteran, I don't have to have that recommendation. So I think that we should give me the free weed card the same way I get the free disability placard. Okay? But like you said, laughing out loud is not allowed. But I'm very serious about that. I don't have access to health care, as other people said out here. I don't have other kinds of insurance. The sign on the back of the VA hospital right here in Oklahoma says, serving America's heroes. But what it really should say is you don't have any other choice. I can't go to any doctor. And the prices that they want, if you go up to Tulsa today, even with the discount, it would cost me about $300 to get a recommendation and license from the state. So I want everybody to consider that as a 100% service-connected disabled veteran from the Vietnam era. I think that we should modify the law to let us have free or extremely low-cost access to medical marijuana. Thank you.
Thank you.
Oh, wait, I got one more thing to say. Yeah, that's right. See, I didn't use any medication yet today. But I'd also like to thank my professor at OCCC for giving me the ability to stand up here and talk in front of all these people. I got an A in my speech class.
All right, we have 1 minute left, so Ray Jennings. You can have 5, but you'll be the last speaker before we, which is perfect because you're the end of this group of 6. Thank you for being here.
First of all, thank you. My name is Ray Jennings. I'm the OMMA Food Board Standards Patient Advocate. I'm also a disabled veteran. I'm part of the group this gentleman introduced you earlier. Our goal as part of that group is to make sure all veterans everywhere has access to what we believe is a God-given plan, and they don't have to pay anything for it. We're here to help them. We're a nonprofit, and we're very proud of that. The second thing I am is a patient. I'm a stage 4 cancer survivor who used THC oil to survive stage 4 cancer, squamous cell carcinoma. I had a tumor on the base of my tongue and mouth the size of a golf ball. I went through 3 months of cisplatin chemo, and I would encourage you to look that up, and 35 radiation treatments right here that burned me so bad I couldn't function. I had a feeding tube sticking out of my gut. I couldn't eat or drink anything, and smoking marijuana allowed me to fight the nausea that was overwhelming every day of my life. I denied this for months as I struggled to survive and was in bed dying as my wife and 2 sons begged me, please, Dad, try this. But as these 2 gentlemen that were sitting here, and unfortunately they decided to leave, I come from a culture that we were raised in the 60s and 70s, and we were told over and over again the evils of marijuana. Stay away from it. It will hurt you. It will destroy your family. It's no good. Crack the egg in the frying pan. That's your brain. I believed all that, as I think all of us believe that. I'm here to tell you, it ain't true. It is a lie. And if you don't believe that, I want you to write down this number and Google it, 663-0507. If you do not agree with what I'm telling you, and it's your responsibility as legislators to represent us, then you need to try at least make an honest effort to educate yourself. And it starts with 663-0507. And if you can at least do that, then you have no right to represent me or anybody else in this state. That, my friends, is the United States government patent on this very plant that we're talking about today. It was filed by the United States Health and Human Services in 1999, and it was approved in 2003. And imagine this, it's for cancer, glaucoma, Parkinson's, Alzheimer's, epilepsy, all these horrific drugs that are killing all of us. How many in this room is a stage 4 cancer survivor? That's what I thought. How many in this room have ever had cisplatin chemo? That's what I thought. I went through every traditional treatment they had to offer, and I had some of the best doctors, which, by the way, 90% of them, almost every one of them, when I looked at them and told them, when I made a conscious decision to treat myself to try to survive, they all looked at me and said, yeah, I know. Yeah, we can't tell you that, though, but we know. So how many of you had a mother and a father as you sat there and watched them die of a horrible death? How many of you? And maybe they could take one. My dad is dead. My mom is 82 years old. My father-in-law is dead, 67 years old, worked 38 years at American Airlines, retired 2 years later, lung cancer. Speaking of lung cancer, Harvard University, and this is something else you need to take responsibility, educate yourself on, filed a study last Friday small cell lung cancer tumors, which is 90% of the tumors in lung cancer, small cell. They did a clinical trial inside the lab, and they did it with mice. They put the small cell cancer tumor in these mice within 3 weeks, using THC only from the marijuana plant, shrunk the tumor by 50%. Now think about that. How many of y'all knew that? No one in here knew that because they don't tell you about it. Is your mom dead? Is your dad dead? Did they die of lung cancer? Chances are it was small cell. I love my mom and dad. I wish I could go back and tell my dad.
Mr. Jennings, your 5 minutes is up.
Sorry. Thank you very much.
Thank you for being here again.
If anybody wants to give me their time, I would gladly take it. I would pay for it. I'm serious about that.
That unfortunately is the end of our time for today. For those of you who were on the list and were not able to speak, we apologize that we ran out of time. We knew that there would be a lot of people who came wanting to speak. We know that through the emails that we get, through the emails especially to our office of people requesting to speak. So we're happy that we were able to at least get through some of those today. With that, don't know if my co-chair has any comments to make, but this will conclude our meeting for today. We will be back here 9 o'clock again next Wednesday. And again, thank you all for being here and for participating.